Okay, you're on the second category right now. The second category looks at bone evaluation. This is something you typically cannot do at home, but if you have a CT and you're able to bring it up on your computer, maybe you follow along, learn how to use the CT software, and you can take a look at, I have pretty straightforward pictorials of what I would be looking at. Like I said, this is for our staff. Some have a lot of dental experience, some have virtually none. And so this brings everybody up to speed. And if you have that opportunity, that'd be great. So let's look at our treatment planning assessment sheet again, our 4 categories as noted before. And in particular, we're looking at the evaluation of your bone. Very, very important if you're working with bone, if you're doing implants, or you're looking at periodontal disease or something like that, you have to look at bone. And if you do not use a CT, a 3-dimensional X-ray image, that's very difficult to overcome, for me at least, because you're not 2-dimensional. 3-dimensional object is really where you have to look and see what you can properly evaluate with your situation. So the first section is bone density. We have 4 categories of bone, and we categorize them as D1, 2, 3, and 4. It just categorizes the density of them. Pretty straightforward. However, the D1 bone density is not good. It's not a lot of healing capacity because this hard bone out here doesn't have a lot of cells that heal bone very much. So for implants, they don't really heal too well in here. They might initially, but then they don't really stay healing. Implants have to maintain a certain amount of healing around the implant while the stress is going on top of the crown. If there's too much stress or any stress and it doesn't have any proper healing, it's not gonna last. It'll just wobble itself out. Same thing with this D4 bone. It's kind of a crude picture. There's many pictures of this online if you want to look, but this D4 bone is very porous, and then you don't have any bone to even hold the implant in either. So we really want to see the sweet spot right in here, right in the D2, D3 area, and that's going to be somewhat ideal. Here's a couple x-rays that I put in the picture. Here you have D2, D3. It's going to be generally in this area. And then our next one here has a little bit more of a combination. It has like splotches of bone here and there, a little bit more porous, and then I have examples of something that's very hard or actually more porous than this. This one actually doesn't look too bad, but this bone, if you were to work with it, you'd find out that there's not a lot there to hold the implant. You're really judging the side walls. Not that you wouldn't try to put an implant in there, but it'd be it would lessen the outcome long term. Facial bone, we talked a little bit about that, and this really has to do with the front part of the mouth and the smile line and maintaining the gum tissue. Here you could see clearly that there is a lip of bone here on the front of this picture here, so we would kind of put that more into the green. Wherever you actually have bone, bone will maintain itself. The thicker the better. Here you can see a sliver of the bone going through. I like this little picture because it's kind of right in between of having no bone. Many of these front teeth don't have a lot of bone in the front already to start. We always call it, in the dentist, call it a facial plate problem, where that bone is not necessarily supportive of the tooth or the implant. It's actually supportive of the tissue that is going around the front of it. So maintaining that's very important. Obviously, we want it to look like a natural tooth coming out of the gums. And then here on the front, this side is the facial side, you have virtually no bone at all the way down. So it's not just coming from here to here, it's actually looks like it ends right about there. So most of the tooth does not have any sort of plate whatsoever. So we don't really like that at all, because when you take that tooth out, you don't have any bone to graft to or try to get reinvigorated to grow bone back into that site. Bone constriction, this is bone anatomy picture. Bone constriction is not this. You'll see pictures of this. This is a big concern. Obviously, anatomy is everything. If you don't have the width and you only have a knife edge of bone, you can't do much with that. Or if you don't have any bone at all coming from the top down, you got a problem. So this is more about bone anatomy. That's kind of a given. It's not something I have on my list. The bone constriction I talk about relates a little bit more to this case here, where you can see it kind of going fairly parallel, and a little bit of a indentation here. So let's look at that. Here's a couple of examples. Here you don't have that at all. It goes in an angle very wide out from the top of the tooth, so you have plenty of room to go with the implant to work in that area. Here's not so much. Here the bone is very thin, but also it's constricted in. It's more like this. If this is that one here, it would be like this big. And then here's a really difficult one. That's a red. You can't do anything with this case. You cannot graft on the outside. And once this thing is extracted, it goes down to a little nub. It goes down to a little knife edge. And many people don't understand that. They think, oh, I have a tooth there, therefore I must have bone. Not so much. That's why you need a CT scan. You could not tell this with a regular Panorex X-ray. That's a two-dimensional X-ray, and you would never see this. You would never tell the difference between any of these in a two-dimensional X-ray. So it's very important. Here's a concept that you have to kind of understand too that can be problematic. Here's just a basic picture of a ridge, and here we have a ridge with teeth. And you can see the coloration is a little whiter, and then you have a redder coloration here. This is where your cheek attaches and flops up and down. So we call that detached gingiva. So you need that movement, but around teeth you don't want the tissue to be moving around, because if you have a tooth here and you have the tissue moving up and down, it gets very sore and can get infected very easily. So we look at the amount of attached tissue, or how much detached gingival height do you have? How much is it coming up on the ridge? So let's look at those examples of what a green would look like, where you have a lot of ridge here, and these have teeth, but you can see the attachment is way down here. Here you don't have so much. Here you can see the tissue stretching, flopping up and down right around this ridge, and here's where the attachment is. So you have even less. So that's a warning on this one. And then here you have it attaches directly to the knife edge of the ridge. Even though they might have a lot of bone, one of the problems could be that down here on the lower tooth that you're going to have to somehow create some sturdier tissue to help hold that in. Here's some examples of some problems, like on the upper where there's no attached tissue height went way up, or the detached gingival height went way up into where the implants are, and you can see it rubbed around on those implants, created soreness and created an infection area, and becomes very problematic. You'd have to go see a periodontist and see what kind of grafts they would want to do. More than likely they would take a graft material from your palate and graft it to that site and try to save everything and restore it so that you don't have any recurring problems later on. Those are generally successful. Now here on the bottom you have 3 implant crowns here, and they have a little bit of attachment, but it looks like this was a grafted one where they thicken the tissue so it doesn't move around as much. So this would be a grafted version. Here up here, this is not a grafted version, but you can see the attached tissue go way up high, and they're just going for it around on that tissue and letting that heal. Sinus bone, you definitely want a CT to look at the sinus bone. Sometimes you can tell on a regular thing, but there are categories of sinus bone, and we want to see this before we take the tooth out if you can. Some people are already missing teeth in the upper first molar area, then it's very clear how much sinus bones you have. This is more about, let's look at it when you have teeth and when you extract teeth. Do you need a graft? Do you need a sinus graft? Do you need a socket graft? How many grafts do you need to try to maintain the bone? Here, if we look at this one, you have the no sinus involvement with the roots at all. That's your best bet of maintaining bone, and maybe you'd graft that. And as you go along, you start to go into the sinus, and the more this shrinks and the more these walls are smaller, the redder it gets. So you want healthy bone all the way around, and it becomes very difficult. You wouldn't be able to put an immediate placement of an implant in these cases at all, you're going to have to graft it. And in particular, these cases, not only do you socket graft it, but you're probably going to have to sinus graft it, especially when both roots go into the sinus. That's a red. That's going to take probably a good 10 to 12 months before you actually see a tooth on there, or even longer. So IA nerve. IA is the inferior alveolar nerve. It's on your lower jaw. We're mainly concerned with the tooth positions 19, 20, 21. So if you don't know the tooth numbers, please look at one of the other videos on the channel so that you can educate yourself about the names and the numbers that we name and number teeth for. So here's a couple of examples. Here we have over here, third molar. That's a problem because the nerve is going where that. We're not concerned with third molars, and we're not concerned with second molars. This is really looking at the height of the bone here and how far away we are from the nerve on these. This is very far away. You have generous bone there too. It looks good. So you know you're going to be okay probably putting implants in over here. The yellow is that now we're getting closer down to where the nerve actually is, and we have this giant bone defect that you're going to have right here across that area when you take that tooth out. So this is a big question mark, because here's the nerve goes up and comes out here. Do we really have enough bone here? This becomes a very questionable scenario. You're going to want to extract that tooth, graft it, and see where it actually heals. You may not be able to put an implant in that site back for that one tooth. I call it a dead site. So and then down here, of course, that's pretty dramatic. The nerve is right below the plate, the top of the plate. You can't do anything about that. You'd have to take that nerve out or move it and then try to do some augmentation of the bone. It's a lot of surgery, and most people don't exercise that. Ridge height. Ridge height is very important, and we want to look at adjacent areas of the ridge height and how that ridge is affected by putting an implant in or doing extractions. And so here there are some extractions. The ridge height looks pretty good. It looks pretty level to where it possibly should be for the top of the implant. Along these other teeth, you have kind of a normal sized crown that would kind of go along here, so that's in my green zone, provided that we have enough anatomy and distance away from the nerve. And then here's where you start to see the anatomy really change. You take out the sinus one here, your bone really starts to fade away, and down here as well, it really starts to drop down. Where there once was a lot of bone, taking the teeth out caused a lot of bone to resorb away. And when you put a partial denture on top of extracted areas where you have a dentulous site, that causes more bone loss. So I'm not a big fan of doing removal of partial dentures. In fact, I don't even do them. I usually recommend somebody else go do them. And you're going to lose a lot of bone. And you want to have something supportive earlier on. Now, here's a case where it becomes very difficult to deal with, because there's all these teeth in here diseasing all the bone, and it looks like, from what I could tell, that's a red all the way across the board from the sinus area up here to the nerve areas down here, and you might have some bone here. So this person is going to be extremely limited on the upper, and probably very similarly on the lower arch, because the ridge height is already destroyed by the disease of the teeth. So if you have diseased teeth and they're moving, you got to get that out as soon as possible. It'll just make the bone worse, and we can't get that bone back. Okay, that's the end of today's treatment plan. That was a lot quicker than the smile characteristics, but we have 2 more to go, so hang in there.